need that to happen, and it's what I'm saying. So
I don't
maybe
know.
that means.
I cannot take it out. I'm still learning the new PowerPoint, Microsoft PowerPoint. So bear with me. All right. So we're going to start. First of all, I want to thank my colleagues. And I also want to specifically thank Dr. Graham, Joseph, Ravi, Roy, Selvi, Sylvia, Sriram, and Sammy. I really appreciate you all joining. This is session 50. It's very interesting. I was talking with Sylvia. We started our first session when Elon Musk sent his spacecraft with a manned crew. And now it's a Virgin Galactic's launch for space tourism. So 1 in 50. Just think about that. All right. So the other thing is I've changed from Keynote to PowerPoint, and I've incorporated poll to see how it works, and we'll take it from there. Okay. All right. So let's do this thing. You may want to open your phones and put poll EV on your Safari or wherever, or Google. And let's see where the heck is it. Okay. So poll EV, and then you can put that username GSR 977. So that way you can join the poll. Okay. Why don't you put in where you live? All right. Did you mark that, Sylvia?
Yes, yes.
Okay. And I'm wondering whether Sammy could do that. Joseph, you did that?
Yep, that's me.
Okay. All right. All right. So at least it's working. So now you can see on the map, right? You did see it on the map. Did you see the markings on the map? You did.
Yeah, and now I think you cleared you hid the responses.
I cleared that, right? So now what is happening is I need to figure out how do I go to the next slide? Okay. So for those of you who want to get CME, you can text 251-2844-912-1333. This works if you've already registered for the MD Anderson free CME. All right. Okay. So this is a case that I've taken from the archives. This is a patient that I took care in 2012. So just bear with me if you don't see all the ways that we image a polyp. Okay. So here we go. So this is a lesion in the ascending colon, and this was found during a screening exam. As you can see, the physician tattooed on the cecal side. You can see the tattoo here on the cecal side. And that is something one should avoid, because if you tattoo on the cecal side and it is confusing for the surgeon, and he will cut just distal to that, And if his cut is not exactly another 5, 6, 7 centimeters beyond that, you may have the polyp entrapped in the resection. So one point I want to say. So let me share this video, and I want to hear your thoughts. All right. Sylvia, you want to take it from there? What your thoughts
Yes,
are?
yes. In my opinion, this is a large flat lesion. It grows more laterally than horizontally, so it's a laterally spreading tumor. We know the location. The size would be it's um, let's say about half of the circumference. In my opinion, I don't see the distal side very well, but it looks like a quite large lesion, so it could be 3 to 4 centimeter in diameter. And if I look to the general appearance, it looks yes, that's the border of the lesion. That's quite a large lesion indeed. And when we look to the general appearance, I don't see any striking features of um, deep submucosal invasion. I don't see converging folds. I don't see a depressed area, at least at this point. I don't see a dominant nodule. And if I proceed with characterization and with a classification first of the lesion, I think that this is a laterally spreading tumor, granular, no, non-granular, flat elevated subtype. And of course, I would very much like to have a look, if possible, using image-enhanced endoscopy, if we have it, in order to further assess the risk to contain submucosal invasion.
All right. Thank you so much, Sylvia. That is perfect. I really like the way you analyzed the lesion. What happened was, this is a video that was recorded in 2012.
Yes,
And
yes,
I was looking for that NBI segment. I think I may not have recorded that. So, okay, let's go to the. All right. So let's, for the sake of just why don't we take your thoughts on this? Just describe what you think.
Very nice.
All right. So at least this process is working.
It's very nice.
And we went ahead and did injection. As you can see, we used saline with indigo carmine. And with the injection, you can actually define the lesion a little bit better, especially when it is such a subtle flat lesion. It is always good to use either indigo carmine or methylene blue to stain and define the lesion. So, Selby, any comments?
Or maybe I have a short comment.
Yeah.
I think that injection allows us at this moment to better characterize the lesion. We have been mentioning that this is a kind of, we call it umbrella sign, because injection helps to unfold the lesion. There was indeed some nodular appearance in the distal portion of the lesion, but as we see now, the submucosal injection stretches the lesion and makes it easier to classify. So, in my opinion, this is indeed an LSD-NG flat elevated subtype.
So this is a low risk compared to the one with the nodules or depression.
Exactly. It's lower risk. It's on average 5% of these lesions contain submucosal invasion. And if possible, unblocked resection is always the best, as we know. But if the lesion is very large, we can perform piecemeal resection in a limited number, low number of pieces, as low as possible.
Okay.
But it's indeed lower risk compared to pseudo-depressed or nodular mixed subtype.
All right.
Someone asked about the size. Yes, I agree. It's a large lesion. It's rather 4 or 5 centimeter than 3 centimeter.
So which type of snare and size of the snare will you use? I think it's a good idea for us to commit. All right. Is Roy there? I don't see whether Roy is here. Ravi, you want to comment on that?
Yes, I will use a stiff snare for this case. It will help us to catch the lesion easily. Preferably, I would use a 20 or 25 millimeter snare, Olympus stiff snare. I'll try to catch it in one piece and take it out, since your lift is very good.
Joseph, any thoughts on that?
Yeah, I'm anticipating a piecemeal here, and 20 is an option, but since we're in the cecum, I mean, even though it's a good lift, I probably might just go with 15, but I agree with stiff snare.
So for the sake of everybody, this is in the ascending colon. So it makes a little bit of difference in terms of picking the snare, right? Yeah. So all right. What electrosurgery setting will you use? All right. Any thoughts on that, Sylvia? Any comments on what people are using?
In general, I try not to change too much from the settings. In my experience, There is a previous setting for right-sided and left-sided polyps, at least in my experience, and I would go for EndoCut 313 in this case.
Okay. Yeah, I think I agree with that thought process. That's what I do. I don't normally change. For all flat lesions, I just use a 313. And if you're worried about cutting a large sessile component in a flat polyp, then I may use a little bit of a slower cut. When I say slower cut, the way I close my snare is at a slower pace so that I have more time to coagulate the vessels than the same tight grip. But one thing is to keep in mind is the worst thing that can happen to an endoscopist is delayed perforation. And it is directly related to the amount of thermal damage that we cause to that patient. So that in turn translates to whether you close the snare fast or slow. So the slower, more current, more unseen damage to the deeper wall, and more risk for delayed perforation. Given the fact that we all have access to hemostatic clip devices now, I prefer to cut fast, and if it bleeds, maybe manage with hemostatic forceps and not have to deal with a delayed perforation. So just wanted to share that concept. Okay. So I'm trying to figure out how to clear this cold thing. Regarding the cold thing, I don't think that I would use a cold snare to remove this polyp. This is a polyp that is not a serrated adenoma. This is a tubular adenoma. And once you have that big of a polyp and you try to cold snare and it starts bleeding, so the capillary wounds, you may not know what you left behind. So I'm trying to see how to get rid of this cold. That's okay. It's okay. All right. So
you need to go to that annotate button and then use the eraser to remove it.
I don't have an
On
eraser.
Zoom.
I don't have an eraser here, to be honest with you.
You done?
I think that's for PowerPoint, and on Zoom there's a separate
On a Zoom. Okay. All right. Thank you. Okay. All right. Okay. That's good. I think I really appreciate that. Okay. So let's go back to this thing. Okay. So we used a 20 millimeter snare. And as you can see here, we were able to cut and block. And something to keep in mind, I want to go back. So one thing is when you have a polyp like this and you use a stiff snare, you can slowly work your way around that polyp and be able to get it and block and cut it in one piece. Wherever you can cut and block, as long as it is safe to cut and block, you should go for it. When I say it is safe to cut and block, that means your operating field is nice and stable, and you're able to reach the site if in case you have a bleed or a perforation, and you assure yourself that the snare is not necessarily grasping the deep layers of the colon. So that is very important when you're doing using a large snare. When you use a large snare, there's a bigger chance to entrap the muscle. So something to keep in mind. So we cut this polyp, and what do you guys think? Ravi?
cut looks good, clean. The base looks fine. I don't see any concerning deep mural injury so far. Looks
Right.
good.
Right.
That's good.
Okay, this is what happens.
Mm.
It's a brisk bleed. And how are you going to take care of the bleed? So let's see if we can actually do some poll on this.
Okay.
All right.
It's multiple choice with a single answer, right?
Single answer.
Mm-hmm.
Actually, there is a way to do multiple choice questions in the poll EV where you can say, I will prefer this first. And my second choice is this.
Okay.
And I can actually put it in there next time. I'm just trying to see how these things work. All right. Joseph, you want to comment?
Sure. So my two sort of options here, at least I might prefer at least trying APC first and see if, as long as I can see the actual source of the bleed. But you could also use a clip for mechanical hemostasis. You know, without deploying the clip, you can keep it on there for maybe a minute or so and see if that might do the trick. But yeah, so there, I think it kind of depends on your style.
Okay, when you do APC, what are your settings and what type of APC? Is it a forward jet APC or a side firing APC or circular firing APC? So you have three catheters. Which catheter would you ask your assistant to pull out? And what will be your settings in terms of the flow and wattage?
I probably use axial straight fire.
Okay.
And so axial straight fire and maybe probably like 0.8 liters per minute, 35 watts.
Okay. All right. That sounds good. So Joseph is just coming off teaching 30 fellows yesterday on electrosurgery, the first year fellows. Congratulations, Joseph. Good job.
Thanks.
All right. So let's see. It's interesting as I'm presenting this, I'm learning that I cannot press my next slide. I have to go to the bar that shows the slide and then click on that bar. So that's why it's very interesting to learn this new system. All right, so I decided to use a clip and let's see. There are two branches, as you can see here, right? You can see the two branches. One here and one there. So let's okay, you saw that. And so two vessels, you can see the cut vessels, and there's something else happening. Okay. what will you do next? Okay. I'm glad that we all picked to wait. I think that's the most important teaching point of this case. And so what we decided was there was continuing to ooze, that small spurt from the lower vessel. And then we decided that we need to grasp a little bit deeper and wait for some time and ensure that there is no bleeding. And once we are happy, then we deployed the clip. And as you can see here, this is one vessel and this is another vessel. I think it's a branching point. And what happened was, if you look at this clip, you have the blades, and this is the so-called center point of the clip, and it is a deep approximation. And if you go back to the previous slide, and let us look at this playback one more time so that you appreciate what was happening and what would have happened if you actually deployed the clip without watching this site. You see there is a gap here. You see the gap here? A small amount of gap. And this is still, this area, this vessel got tamponade, received the tamponade, stopped bleeding. But this vessel continued to bleed, as you can see that. That small spurt of bleeding. And I'm glad that you all picked correctly to wait for some more time rather than deploy. And it's very important to share this with your assistant, that the assistant will only deploy when you say deploy the clip. And they should not automatically think that they are in control and deploy the clip. So you can see here, right? That deep approximation is very critical. If in case, if I've actually deployed the clip without controlling the bleeding from the second vessel, I would have struggled to control that bleeding because you don't know whether the vessel came straight up, perpendicular to the wall, or it had taken a course. If it had come straight up and the previous clip has not worked, you will not be able to apply another clip to control that bleeding by putting another clip adjacent to that, because there's no space. So something to keep in mind. Any comments on that?
Maybe a short question,
Yeah,
if possible. In the past, we have used APC in combination with clipping because it has been shown that the combination is better than either APC or clips alone. But I very much enjoy this trick, and I will use it. I mean, reaching hemostasis, mechanical hemostasis by clipping directly and waiting for a few seconds until bleeding stops, and then deploying the clip. My question is, are you still using APC, or you never use APC anymore? You always do it in this way?
I'll answer that question after everybody answered. Let me ask each one's preference. Joseph has already said he's going to use APC first. Let me ask Ravi, Aman, and
I
Sylvia.
would use coagrasper to coagulate the bleeding vessel, and then I will close the defect with clips, and maybe APC the edges before I close. So for brisk bleeding like this, I would prefer coagrasper because that would help you to precisely coagulate the blood vessel.
Okay, that's a good idea. Aman?
It depends on the inner situation and where I am in the process of doing the EMR. If I am in the beginning stages or still have a lot more to do, I try to avoid cautery if possible, so that any type of cautery, so that the remainder of the polyp and is not any kind of fibrosis or any kind of like not fibrosis but any kind of like interference with that. So mechanical may work better, and it also depends upon the angle and the situation where it is in respect to the remainder of the cutting field. So there's no one answer to, I think, that question. It is very situational, but I like to do more mechanical than APC, partly because I'm biased. I learned that from you.
All right.
Mm-hmm.
Selvi? All right. So I think it's a good topic to talk about. Say, for example, I want to, this is a vessel that nowadays, but if I were to do this, I may have used a hemostatic forceps because it works very well and you can control the bleed pretty good. On the other hand, if you feel that, okay, you finished the job, there's not much else to do, and you don't have a hemostatic forceps in your lab, then clipping actually works very well. And it's important for us to keep in mind that once you apply the clip, you need to wait for at least 15-20 seconds to assure yourself that the bleed has certainly stopped before you deploy the clip. I think that is the most important principle that I would like to share by showing this case. The second thing is I've had a big bleed similar to this bleed in the past, a vessel probably about this size or even slightly bigger in the rectum. And at that time, I did not have access to hemostatic forceps, like in this case. This case was done in 2012. We did not have hemostatic forceps available at that time. It is a relatively recent development, hemostatic forceps available in the US. So at that time, I used the same reopening function of the clip, applied tamponade to make sure the bleed stopped, and sat there for almost 5 minutes. And the reason I sat there for 5 minutes was because there was still quite a bit of polyp that I needed to cut. And by sitting there and occluding on the vessel, 5 minutes will allow you to form a decent clot so that you could reopen the clip and then go ahead and do the remaining resection. So that is something to consider. The other thing is the hemostatic forceps may not work in certain cases. And one case I would like to share is when a vessel is at the edge of a resection, and once you cut the polyp and you see bleeding, and the vessel actually retracted underneath the edge, and you can't find that. I had a case like that where I tried to use a hemostatic forceps because that happened in the last 2-3 years. Because of brisk bleed, I said, hey, I may be able to cauterize that with hemostatic forceps, but I was not able to see the vessel because it was pumping fast. And I tried to apply cautery a couple of times more blindly, to be honest with you, and it did not work. And then what I did was I applied a clip basically grasped the edge from here and then went up all the way to the other blade was on that side and basically closed the edge down to the base. And by doing that, I was able to control that bleed. So something to keep in mind, depending upon where the vessel is, how the vessel traverses through the wall of the colon, and whether it is in the middle of the resection or underneath the edge. So just a few thoughts in terms of controlling bleeding. All right. So then we decided to basically close the defect. And as you can see here, we're closing the defect. Although you have a clip, half of it is, one of it is, the first one is in the base. We're able to close the defect. And this actually patient turned out to be tubular adenoma with multifocal high-grade dysplasia. And the patient did well without any post-operative complications. So any questions or comments that people want to talk about? Okay, I didn't see Sriram. Sriram, I want to hear your thoughts.
I'm biased for coagulating first before clipping, sir.
Okay.
And the same effect of grasping and waiting to see if that mechanical grasp will help slower the bleeding or not can be done with the coagrasper as well before applying the coagulate. My bias towards this is because if clip doesn't control, at least I'm not in keeping a metal in my field for subsequent cautery application. And I might even, if the bleed is so brisk and I'm unable to, then I might even think of injecting to slow down the bleed and then tackle the vessel. I would keep my mechanical options to the end. But then it is individual comfort levels, I guess.
So what are your settings when you use APC and what are your settings when you use coagrasper?
The coagrasper for we basically using soft coag, so 80 watts is the one, and for APC I just use the right colon setting. For the APC machine already has the settings in place.
Okay, that's good. So any other comments?
Beautiful case.
One thing that I was talking to the fellows yesterday about, using these snare devices is, anticipating, depending on the size of the lesion, anticipate how you might modulate your endocut Q settings. So actually, I was the one who on the poll earlier, I wrote 314 because I felt 316 was a little much for the right colon with the interval cut interval of 6. Just because I didn't want that extraneous thermal effect. But at the same time, I felt 313 might have been just a tad less, because if I'm not getting that coagulation effect, then there might be a slightly higher chance of bleeding vessels. So I settled for somewhere in between. So you could probably use like 314 or 315.
Yeah, that sounds good. At the end of the day, what happens is, you also get into the habit of how fast or how slow you close that snare handle once you keep your settings at a particular level. That's one thing we all develop. And that's how we try to compensate. That's good. All right.
I have just one more comment. For small bleeds, I do use the tip of the snare for coagulation because the laziness to get another accessory. But the bleed that you showed, although it may be tempting, I wouldn't use the tip of the snare for this hemostasis in this case. Main concern being in the cecum and the briskness of the bleed and lack of control with the tip of the snare.
Yeah. The other thing is actually, for the sake of, let me ask you a question. So for those of us using Irby machine, you have the endocut on the left side, and on the right side, usually it is set as forced coagulation. And what I've started doing is when I do my EMR, I basically change the force to soft at the beginning of my case. So on the left side, I have the cut, and on the right side, I have the soft coagulate. So if I see a bleed, I'm not asking the assistant to change. I'm basically using the blue pedal and control the bleed. All right. Let me request Sylvia to summarize the take-home message. Sylvia, I really appreciate your
Yes,
input.
yes, of course. That's it's a very instructive case. So this 60 years old patient came for a second opinion, if I'm right, for endoscopic resection of a large flat lesion in the ascending colon. What we performed was diagnosis first. We appreciated the general appearance of the lesion, whether there are any signs of submucosal invasion, which fortunately were not present in this case. Then we attempted to classify this lesion, and we agreed that it is a laterally spreading tumor non-granular subtype, flat elevated subtype. And we did not have image-enhanced endoscopy, as this was an older case. The lesion was large, and we decided to inject. When we injected, the lesion lifted adequately. We could better appreciate the morphology. We could better appreciate even the epithelial surface. We expected that this is an adenoma. No signs of, again, of deep submucosal invasion. We chose the materials. Actually, we had to prepare these materials before starting the procedure, if I'm correct. So we chose to use 20 millimeter stiff snares. The stiff snare is very important because it's a flat lesion, and the endocut 313 or slight changes according to everyone's experience. And nicely, this lesion was nicely captured actually and suitable for unblocked resection. What I would suggest in this case, in order to avoid entrapping of the muscle, once we capture the lesion, we can instruct the assistant to first to very slowly close the snare. And when they feel the tissue, I always ask them just very slowly release, and I try to make sure that I didn't entrap the muscle by moving the lesion back and forth a few times. When I'm sure that it's safe, then the lesion can be resected. And we observed that we observed a bleeding immediately after resection, and we discussed about how to treat such bleedings. Of course, this decision is based upon the size of the blood vessel, location, and also local experience. We have learned a very nice trick to apply clipping directly and wait for mechanic hemostasis, which I will try in the future. We should wait at least, I understand, 20 seconds to make sure that the bleeding stops. Alternatively, we can use APC before, followed by clipping or coag grasper if it is available. And in the end, we nicely close the defect. And the histology confirmed actually our diagnosis. And the nice thing is that these laterally spreading tumors, non-granular subtypes, there are several studies. I would mention one in endoscopy from National Cancer Center, in which they showed that the risk of submucosal of multifocal submucosal invasion, in this case multifocal high-grade dysplasia, is high in laterally spreading tumor non-granular subtype. So they can pose resection challenges. And the lesion was resected en bloc, so the pathologist will be happy, I think, in this case, because he can assess presence of multifocal dysplasia.
Oh, thank you, Sylvia. Beautifully done. You're amazing how you do that. So really appreciate
Thank
it.
you.
Thank you. All right. Any last minute questions? Come on.
No, sir. All good.
All right. All right. So just bear with me. I think we'll try and do this type of presentation using Pole EV. It's a little bit of a learning, to be honest with you, because it doesn't flow like a regular PowerPoint. You have to click multiple buttons to get to the next slide. But it looks like the system works. And I want to thank you all and hope you all have a
Thank you so
great
much.
weekend. All right. Take care.
Thank
Bye-bye.
you so much.
Thank you
Take
too.
care.
Thanks
Thank
everyone.
you.
Take care.
Take care.
Take
Bye.
care. Take care.